This instructional video will demonstrate how to properly insert and administer an epidural catheter for continuous analgesia with the patient in an upright, sitting position utilizing a midline approach. Review patient history. Complete patient assessment and note patient allergies. Be sure to check patient lab values, specifically platelet level. The lower accepted level will vary from institution to institution. Obtain patient consent. Apply appropriate monitors. The patient can be placed prone, lateral, or in the sitting position. However, this video will demonstrate placement in the sitting position. The patient should sit on the bed with legs dangling off the side. To maximize the space between the spinous processes, the patient should arch the back into a C shape. Locate anatomic landmarks by first identifying the tops of the iliac crest, called Tafir's line. This is typically around L4. The midline is identified by palpating the spinous processes. Make sure to feel for the soft area between spinous processes to locate the inner space. Either L3 to L4 or L4 to L5 can be used to introduce the epidural needle. Prepare the patient for the procedure. Open the epidural tray and don sterile gloves. The patient should be prepared with an antiseptic solution. The solution must remain in contact with the skin for at least 1 minute to be effective. Maintain aseptic technique and apply the sterile drape to the back. Perform a timeout. Re-identify your anatomy. A rapid-acting local anesthetic such as 1% lidocaine is used for local infiltration. Raise a skin wheel to place the local anesthetic into subdermal tissues most likely to contain nociceptors. Deeper tissues can be anesthetized by spreading local anesthetic through the tissues in a fan-like pattern. Epidural needles are larger and more rigid than spinal needles, and the placement does not require an introducer. The needle is placed with the bevel up. Slowly insert the needle through the skin, subcutaneous tissue, fatty tissue, supraspinous ligament, interspinous ligament, and possibly into the ligamentum flavum. At that point, the needle should sit firmly in the midline. Remove the stylet. Determining which ligaments are being passed through is an acquired skill. The interspinous ligament may feel gritty against the advancing needle, while the ligamentum flavum offers more resistance. The depth from the skin to the ligamentum flavum generally ranges from 4 to 6 centimeters in normal-sized adults. After the ligaments are penetrated, the anesthesia provider should not change the direction of the needle tip without withdrawing the needle several centimeters or to the skin level. After the stylet is removed, the needle is slowly advanced using the loss of resistance technique. A loss of resistance syringe containing 2 to 3 milliliters of normal saline or air in a freely movable plunger is securely attached to the needle. If the needle is in the ligament, it should not be easy to inject saline or air, and there should be some resistance felt when slight pressure on the syringe plunger is applied. Make very small movements by having some sort of support and advance toward the epidural space by application of pressure to the needle. As the needle passes through the ligamentum flavum, resistance increases. Once the bevel of the needle finishes going through the ligamentum flavum, an immediate loss of resistance occurs and the contents of the syringe can be injected gently without resistance. Once the contents are injected, firmly hold the epidural needle and remove the syringe. An epidural catheter is threaded through the needle and into the epidural space to a depth of 3 to 5 centimeters. Once the catheter is threaded to approximately 3 to 5 centimeters, the needle is withdrawn slowly over the catheter. Once the epidural needle is removed, the catheter depth should be noted and documented. Secure the epidural at the site with an adhesive foam dressing. Secure the epidural catheter and apply a tegaderm to ensure the epidural catheter position does not change. Additionally, it is common to tape the epidural catheter, as these catheters are often in place for extended periods of time. A catheter to syringe adapter is placed on the free end of the catheter. Gentle syringe aspiration is applied to the catheter. However, a negative aspiration test does not guarantee that the tip is in the epidural space. The catheter adapter can be connected to a pump programmed with low concentration local anesthetic, ensuring that the patient is receiving a constant amount of local anesthetic per hour.